Chang from Geisinger Health in Pennsylvania, presenting to us today on genomics in the large cohort study. Dr. Chang is a physician scientist at Geisinger Health, which is this, large, I don't know, would you call it an HMO-like organization in Pennsylvania? He's a physician scientist. He is the acting co-director of the Kidney Health Research Institute there. His research work actually spans a lot of areas. I know him from his work in hypertension and cardiovascular health and kidney disease, but now he's doing work in genomics as well. And he's got some exciting data to share with us today. Welcome, Alex.
Wonderful. Thank you guys so much for the invitation. Thank you, Swap. So I have a lot of slides, so I might talk a little bit fast to try to cover as much as possible, because I think it will be interesting to folks. And then I'm happy to take questions at the end, and we can go from there. So my disclosures have some grant support from Novartis, Novo Nordisk, Bayer. In the past few years, had some research fund consulting for Novartis, Amgen, Medscape. Learning objectives today to describe the genotypic and phenotypic spectrum of ADPKD, improve recognition of potentially undiagnosed Alport Syndrome in patients with hematuria and proteinuric kidney disease, and then also understand differences in prevalence and severity of genetic kidney disease in the general population versus disease-focused cohorts. So this is probably a familiar figure, hopefully. This is from Dr. Garabi's group. This was published in 2019, where they did whole exome sequencing at patients at Columbia who were evaluated for nephropathy, and also end-stage kidney disease patients from a large statin trial. And the kind of surprising thing was that 9% of the patients had a diagnostic variant in one of 625 nephropathy-associated genes. I think the important thing to know is that, really for us, it's that the main things that we're going to see that are common are ADPKD and Alport syndrome, and that there are these rare genes that are associated with kidney disease that are also in this mix here, but usually just a couple of cases here and there. Of course, ADPKD is another big contributor. Today, we're going to focus mostly on ADPKD and Alport syndrome. So this is a nice review paper looking at different diagnostic yields that have been reported in various cohorts for different kidney disease conditions. So if you have ADPKD, you can see those diagnostic yields are pretty high in these cohorts. A little bit lower for nephrolithiasis. You can see a lot of these 95% confidence intervals are very, very large, and you can imagine the variability in these studies of what exactly is the population being studied. Are they kidney transplant patients? Is it a pediatric nephrology clinic? All those things matter, and it's kind of hard to generalize all these findings, but it gives you some general sense for the diagnostic yield. This is another paper. This is from Dr. Dahl and a bunch of authors from the Natera that worked in this study funded by Natera, which is a company that does a genetic kidney disease panel. So they found that diagnostic yield was highest in cystic nephropathy, and then for hematuria it was 35%, and you can see everything else is sort of in between. Even nephropathy associated with diabetes, and this is probably whatever people write into the case report for when they ordered the test, was around the 10% range. And then a lot of the findings were helpful in terms of diagnosis. Some of them were just confirmatory, but I think that's still helpful to patients. A lot of times the patients will say that even if it didn't tell them something totally new that they suspected, they're very happy to have an actual genetic diagnosis. And then there were a few that were reclassified. Now, the problem with these studies is that, it's really kind of this iceberg metaphor. We're sort of looking at the most serious disease when we're evaluating patients in clinic and considering, this kind of, raises my spidey sense that this could be genetic or not. And then those are the patients that are getting tested. and then those are the ones that end up being reported in most of these cohort studies. So what are we missing if we take what we call like a genotype first approach, where you start with the genetics, you see if somebody has a pathogenic variant in one of these genes, and then you see what kind of disease manifestations they have. So this is a good example of why that matters. This is looking at monogenic diabetes, published by a colleague of mine here at Geisinger. So they use data from the UK Biobank, from our Geisinger MyCode cohort study, which I'll show later, and then from Exeter, where they have a very monogenic diabetes focused expertise clinic. And so you can see, if you look at the Exeter data, almost, of course, they're coming there for that problem. So 100% of the probands have monogenic diabetes. If you look at the affected family members, it's a little bit lower. It's more like in the 80 to 90% range. If you take MyCode, which is a health system-based cohort of patients that are seeking care in the hospital and clinics at Geisinger in central and northeast Pennsylvania, so they tend to be a little bit older, probably a little bit more disease than the general population, but eventually people see the doctor. But you can see that the prevalence of diabetes is about 50% by age 40. And then UK Biobank tends to be a little bit healthier than the general population. And so you can, and then it's probably, maybe less disease compared to our health system cohort, and their prevalence is in the 30% ballpark. So you can see that, these things will matter if you're trying to, if we start doing a lot more genetic testing, and then people get incidental findings and how we interpret what that means for their actual risk. So that being said, we looked at Geisinger, which has this 175,000 patients who underwent exome sequencing. What happens is you have patients who would show up to clinic, and we'd have consenters at all the different primary care clinic sites and around the hospital at different locations, and they would kind of rotate them around and try to get a general sampling of the overall clinic population at Geisinger. And so this is funded through a collaboration with Regeneron Pharmaceuticals, and as a result, we have all this exome sequencing data, and we have a long-standing EPIC electronic health record since 2000 or 1997, I believe. And so we have lots and lots of clinical data to look through to try to understand what all this means. So with that, this would be a great opportunity to look at ADPKD. And I had a colleague who, Turaj Mershahi, who was interested in ciliary function and had done some basic science in that field. So for this study, we're taking this genotype first and phenotype first approach, evaluate ADPKD, decipher monogenic causes of ADPKD, and also test the hypothesis that protein truncating variants in genes that have been described in cystic kidney disease would be associated with PKD. Most of the things, are often in various case reports, and there's some, basic science work done to show that there's an effect on polycystin levels with these various genes. So this is just showing a background. The general thought now is, so you have PKD1 and PKD2, they encode polycystin 1 and 2. These proteins interact, they form a putative receptor channel complex on primary cilia, and there could be second hit somatic mutations affecting the normal allele. There is a thought of this threshold model where you could acquire a critical level of low polycystin 1, and then you're more likely to develop a cyst. And so if going off of that, then if you have genes that encode proteins that actually affect the post-translational protein processing of polycystin, then you can also affect the polycystin dosage as well. So these are some of the other putative genes that have been described. A lot of the work by Dr. Bessie and the Yale group. So again, this is MyCode. I think we talked about what this is. We have exome sequencing data. We also have gene chip array data as well. And so what we have is the clinical data with Epic and PACS imaging data, billing data, lab pathology, medications. Then we have all the genetic data. Then we basically develop some phenotyping here, and then we run all the genetic stuff through our pipelines and look to see where there's associations. And this allows us to look at, try to understand, known genes, and then also look at potential new discovery. And then the very cool thing about the project is that since the beginning, they envisioned this as a way to also try to help patients. So there's this American College of Medical Genomics group that had come together about what results could be most actionable. And so there was a list of several genes on that. Not many kidney genes that were on the list. They're mostly cancer and cardiovascular, but ever since the beginning, they planned out this returning results feature where they actually will tell patients if they have BRCA1, BRCA2, et cetera, and then provide genetic counseling and give them advice and try to get them the appropriate screening tests as well. So we'll skip over some of this. The only thing to really note is that there is some sequencing nuances with PKD1 because it's a very large gene, and there are these pseudogenes, which are repeated segments that are very large, and that can confuse the variant calling. So we had to develop some specific algorithms to try to identify unique sequences that were next to these pseudogenes to be able to make sure that we are capturing the true mutation in the area that we think it is. And then we also looked at copy number variants with some software. And then there's various databases that you can use to look at whether a variant is pathogenic or likely pathogenic, or what people have called it before. So the Mayo ADPKD database is considered probably the gold standard here because it's maintained by Dr. Harris and others, and they review a lot of different data to try to give it a status of pathogenic or likely pathogenic variant of unknown significance, benign. So for the phenotyping, what we do here is, we started off with the ICD code diagnoses, and we know those are not perfect. So then we also looked at, some of those other kidney cyst codes you might use, like cystic kidney disease or liver cyst, and then we chart reviewed all these with at least 2 physicians, including a nephrologist. This was a lot of different trainees over the years. Then we had a great radiologist who was happy to review them and actually was counting as many cysts as possible and try to classify them, and then had looked over the Mayo classification strategy for imaging to subphenotype them as mild, typical, or atypical. We don't have MRIs on every single patient. Most patients don't have MRIs, so we couldn't exactly calculate total kidney volume because there's different imaging modalities. So this was the best attempt we had to do the subphenotyping for the imaging. So among the 303 patients with ADPKD ICD diagnosis, the mean age was 61. Most of the patients in our area are European ancestry because we have a lot of follow-up time, 18 years. And as you'd expect, they're at higher risk compared to patients who don't have ADPKD with hypertension, end-stage kidney disease, nephrolithiasis, heart failure, cystic liver disease, cerebral aneurysms. So this slide is showing prevalence of PKD by different approaches. So often quoted would be like 1 in 1,000. So if we look at the confirmed ADPKD, we got about that 1.35 per 1,000. A little bit more if you just use any ICD diagnosis. Now, if you look at the pathogenic variants, so this is the right 2 columns are the genotype first approaches. So if you include just the ones that are called pathogenic, then that would be about similar, about 1.93 per 1,000 persons. But if you include the ones that are likely pathogenic, which includes a lot of the missense variants in PKD1, then you can see there's this discrepancy where there's a much higher prevalence, which can't really be true in terms of what we typically think about for ADPKD. So what does this mean exactly? So, this is some other ways that we're visualizing data here. So like, okay, if you start with the patients who have a protein truncating variant on the left, you can see that almost all of them do have ADPKD, 98%. If you look at the ones with likely missense variants, likely pathogenic missense variants, then only about a third of them had ADPKD. And this is looking at only including patients who actually had imaging data and were of sufficient age for us to call them as having, clinical evidence of ADPKD or not. So this was kind of surprising, I think, but it was also similar to some other papers that had come out showing that these predicted likely pathogenic variants prevalence is a lot higher in the general population than you would expect. So, I think this helps confirm that. Now, this is a plot that shows all of the different cases that we had. There's a lot of information, so we'll just focus on that. 180 out of 235 of the patients that had ADPKD confirmed, so about 77% had a potential genetic cause. And I say potential because some of those likely pathogenic or variants of unknown significance, we can't say for sure that they're causing it, but there's reasonable likelihood considering they have ADPKD. So 83% were typical ADPKD, 10% were atypical imaging, 7% were mild. And of course, PKD1 and PKD2 were the most common, accounted for most of the cases. However, 8% of them had genes and other genes associated with cystic kidney disease. So if you look at this subset, you can see that a lot of them, the patients that have mild or atypical ADPKD, a good chunk of them have these other genes, and this included IFT140, which is the third most common cause of ADPKD, and this has been shown in a couple other cohorts as well. And then we had a patient with the ALG8 mutation, GANAB mutation. There was one patient who was heterozygous for PKHD1, and this usually causes autosomal recessive PKD, but there are reports sometimes where there's a patient who's heterozygous for that mutation. And you can see for GANAB, this is a family that has a couple of patients that are affected. And it's kind of this milder cystic disease. I mean, some of them are large, but overall, the overall cyst burden is not great. And most of the patients have a milder presentation than PKD1 or PKD2. This is just showing basically the same thing, looking at the different types of atypical genes, atypical phenotypes and mild phenotypes. And some of them also have PKD1 variants of certain significance, but some of these variants have a milder impact on disease. That's possible as well. So this, I think all this was interesting. And then the truncating PKD2, so some of them were mild or atypical. And as you know, you can get more severe or less severe presentations for PKD2. In terms of diagnostic yield by family history, it's higher for those with family history, so that's as expected, and then also higher for typical versus mild or atypical imaging phenotype. So still, a lot of the patients did have a genetic cause. Now, when you're looking at like a genetic test report, if you order a PKD gene panel, and now we're getting more and more of these genes added to these lists. So it's always important to try to understand what the evidence is behind each of these genes, because some of the panels will have genes that are more or less associated with the disease. So like ClinGen is a group, and there's other groups in the UK that curate these gene disease association lists. So the ones that are considered definitive are right now GANAB, HNF1 beta, PKHD1 as autosomal recessive disease, some of the polycystic liver disease genes, PRKCSH, a lot of alphabet soup. And so this is good to kind of review if you come across a gene that you're not sure exactly what that is, and these things are always changing on an ongoing basis, so they will be updated frequently. So this is the analysis where we just looked at patients, who have a gene, a protein truncating variant in one of these genes, and whether they were at higher risk of ADPKD compared to controls. So, these odds ratios are massive for PKD1 and PKD2, which makes sense. And then you can see GANAB and HNF1 beta were strongly associated, as was IFT140, and then a kind of borderline significant association with PKHD1 heterozygotes. And this is ADPKD ICD code, so that's the 300 subcases. Now, if you go to, also this other one here, LRP5, I just included on the list here to highlight because this had been previously implicated as a potential cystic kidney disease gene, but you can see from our results, I mean, there's 1,400 patients and none of them have ADPKD. So sometimes some of those, case reports of things end up being erroneous, and that one don't believe is real. In terms of like this kind of milder kidney liver cyst phenotype, so we had a lot more cases of those that had ICD cases, and we used that to look to see if is there any signal with some of these genes. So GANAB, HNF1 beta, IFT140, again, these were associated with any kidney or liver cyst ICD code, and also ALG8 and SEC63 as well. And all this makes sense that if you have some mild alteration that may affect a polycystic dosage through some of these mechanisms, then it could lead to the disease, but it's not going to be as strong as having a more direct mutation in PKD1 or PKD2. So we had looked more closely with Whitney Bessie at Yale and Steve Somalo to look at this ALG9 candidate gene. They had identified it in their polycystic liver disease cohort that they had. And, they noticed some of the patients also had kidney cysts, and, the difference between the kidney and liver cyst pathogenesis is beyond me, but they're, clearly linked. So they had us replicate analyses, and we found that, most of the patients that had ALG9 mutation, protein truncating mutations above the age of 50 had at least 4 kidney cysts. But these types of pictures are much more milder disease. They typically don't have very large kidneys, and there's some more images of representative patients in our cohort. Another gene called ALG8 was also implicated as a potential polycystic liver disease gene, and I'll mention that that's kind of interesting because a lot of times it's a great strategy to identify a unique phenotype, but you don't necessarily see the polycystic liver disease when you look at the general population. So what we found was that patients that had ALG8 protein truncating variants were at higher risk of kidney cysts. There was not a whole lot of liver cysts in these patients. It doesn't show up on this visual abstract because I think it was negative, but they were at higher risk of kidney cysts and also nephrolithiasis as well. And we had much stronger results when we actually looked at the images with the radiologists and categorized the patients. So 58% versus 8% in controls, which were drawn from a related group that did not have the gene variants. Notably, it's a pretty decent sample size. I don't think any of the patients had end-stage kidney disease. So if you have this particular gene variant that shows up in genetic testing with somebody with, maybe a more atypical presentation of PKD, they don't have family history, or maybe they have some remote family history, but nobody's on dialysis or anything. I think it's pretty reassuring that, they're not necessarily going to be at high risk. These aren't patients that, you're thinking they're going to need tolvaptan or something like that. Here's some more images of patients with ALG8 mutations. And you can see a lot of them have very small cysts that are hard to appreciate in various instances. And so anytime I see some, clinical picture like this, I'm kind of thinking it could be one of these gene mutations. Doesn't necessarily mean we should test for all of them, but if there's a specific reason that you're concerned about, I think it is helpful to have the genetic information. So in summary, prevalence in a largely unselected health system population was about 1 in 700 for ADPKD, six-fold higher if you include the likely pathogenic missense variants. Some of those are probably not actually pathogenic. I think that's possible, or some of those missense variants may have intermediate penetrance, and maybe there's some modifier genes or other second hits that could result in having ADPKD. And then 8% of the patients had rare variants in other kidney disease genes. And we found that the genetic diagnostic yield was higher in family history and those with typical imaging. I think the implications are that, this exome sequencing seems to be pretty decent for, detecting PKD1 and 2 with the appropriate pipeline. A lot of these gene panel tests will have an exome backbone that's being used and becoming less and less expensive. Now, because of that, if you have a whole exome analysis ordered, sometimes there's these incidental findings. So right now, PKD1 or PKD2 are not considered on the list. And I suspect that has to do with, maybe less representation of nephrologists on these panels. But, clearly these things could be actionable and should be considered in the future for, returning results. All right, so I'm going to move on to Alport syndrome. Again, this accounts for, about a third of those genetic causes of diseases in Dr. Garavi's study. So we know that, the autosomal recessive X-linked forms are very severe. We actually have a lot more patients with these heterozygous mutations. And it could be either COL4A3, 4, or 5. And you might have, thin basement membrane disease, familial hematuria. It's actually the most common genetic finding in FSGS. And you might have patients with end-stage kidney disease that is misdiagnosed that may actually be related to Alport syndrome. So prevalence in the population varies from 1 in 5,000 to 53,000. And, these are more reflective of mostly X-linked and autosomal recessive disease. So you have to think about how definitions of diseases change over time. So now that we're in this environment where we have a lot more genetic testing, if you're thinking about, genotype first, then from Judy Savage's group, the prevalence of predicted pathogenic variants is 1 in 106, which is pretty common for COL4A3 and 4, and COL4A5 is 1 in 2,300 individuals. So this is a paper that we published last year, and we took the same approach. We just looked at COL4A3. Why did we look at COL4A3? We happen to be seeing a lot of patients in clinic with COL4A3 that when we did genetic testing. And there was a particular variant that kept popping up. So we're like, okay, let's start with this and try to develop a phenotyping strategy. And try to look at these genotype-phenotype associations. So just to orient yourself, this is that KDIGO heat map, but I inserted an extra set of boxes for having preserved GFR with hematuria. So you'll see this pop up. We compared the patients with the variants versus propensity score matched controls, and then we compared different types of variants. If you have a variant in the glycine variant in the collagenase domain of COL4A3, 4, 5, that's part of that triple helix. So those are usually pathogenic. Then we looked at protein truncating variants separately if they result in early termination or truncating of the variant. So 3% of the patients had a variant in COL4A3, 0.2% had a previously described pathogenic or likely pathogenic variant. They're more likely to have Alport syndrome features than controls. And the population looks, overall the demographics look similar to the other slide, but we'll see that most of them have EGFR data available. Most of them have urinalysis available as well, so that's helpful, so we can look at hematuria, and only about less than a third have ACR available. So the odds ratios for glycine 695 arginine, it's just one of those glycine collagenase domain variants. It just happened to be there's a lot of patients, must have been a founder population that come over to our area. And that one has been reported in the UK Biobank and in Iceland's cohort as well. So you can see the odds ratios are pretty high. They're a little bit exaggerated compared to a relative risk because having hematuria can be kind of more common than other traits. Yeah, increased risk of dipstick hematuria, kidney failure, and EGFR less than 60, EGFR less than 30. If you looked at protein truncating variants, you can see that the phenotype is a little bit milder with the odds ratios. Some of them are not significant, but for kidney failure was threefold higher. And then other missense variants, that was kind of this leftover group of missense variants that were not those glycine collagenase domain variants. You can see that most of those things were not significant. And overall, patients with COL4A3 disease don't really get that bilateral sensory neural hearing loss or eye features. We don't have a lot of eye data, so that's very hard to capture in the electronic record. Compared to controls, this is that heat map showing here. So you can see there's a lot more hematuria and moderately increased risk by the KDIGO risk scores in high and very high, extremely high risk compared to controls. And then this is just showing the older group of patients. If they're 65 plus years old, you can see as you get older, you're going to be at higher risk overall. So you have, a lot of these patients are presenting later on, and you can see that 53% of them had high risk or greater disease at 65 and older. Diving in more closely into their charts, some of the patients had 19 had end-stage kidney disease. The mean age of onset was 58 years. And it was hard for the clinicians to distinguish it because, there was only 2 that were called Alport Syndrome. There was some nephrotic syndrome with FSGS. This is our US RDS data form. When you register a patient for end-stage kidney disease, you have to write a listed cause. All the other causes were all over the board of hypertension, cholesterol emboli, type 2 diabetes, IgA nephropathy, PKD even. And there's been some association of kidney cysts in Alport syndrome that has been described in the literature. 11 patients had kidney biopsies, and 6 of them had FSGS. 1 had thin basement membrane disease. 2 had IgA nephropathy. That was the written diagnosis. And you can, just try to look at through the electron microscopy to get some sense about, some of the other EM findings. And there was some thin GBM noted. A lot of them did not really note having, thin or thick GBM. There was one that did have more variable GBM thickness, which is often seen. And then, just really want to highlight that, most of the patients did not have albuminuria testing, and only about a quarter were receiving ACEs or ARBs. And so, I think that offers some interesting food for thought of whether, we should be doing more genetic testing. The limitations are that, this is all EHR data, but we try to do our best to look through all the lab data, including the urinalysis data. We're going to need more diverse cohorts. A lot of these results are actually quite different from what's been published. So it'll be good to replicate it in other unselected cohorts to get a better sense of this genotyping first strategy, what that will look like for patients. So, the phenotypic severity was actually varied by genotype, which I didn't talk about too much yet. So the most severe expression was for glycine collagenase variants, and it was actually intermediate for truncating variants. In the literature, there's some suggestion that protein truncating variants would be more severe. So we thought this was interesting and ran contrary to what we sort of expected. One theory that we had was, the non-collagenase domain in this C-terminus for those cohort 3, 4, 5 chains, they're actually needed to initiate that protomer assembly to form these triple helixes. So, perhaps protein truncating variant carriers, they have a protein, the functioning allele is producing a decent protein. So maybe that's sufficient or, partially sufficient for basement membrane function. Whereas if you have somebody who has something messing up that glycine missense variant in the collagenase domain, that sort of will form a more, malfunctioning basement membrane. So that's the theory that we have. And we're going to look at more of the data from cohort 4 and cohort 5 and other cohorts to try to see if this holds true. This is unpublished data looking at cohort 5, but I was a little bit surprised to find similar things with cohort 5. I had sort of thought that 100% of patients of males would have end-stage kidney disease by the time they were 30 or 40 per the literature. But again, this similar thing where we focused on patients who have definitely pathogenic variants that are well categorized in ClinVar, and then looked at the males and the females. This is just showing kidney failure-free survival. So about at age 40, the patients that had the likely pathogenic variants who were male, about 75% of them were still alive without end-stage kidney disease, and there was even some older patients that did not have kidney failure. So this I want to try to replicate in some other cohorts to see if it holds true. There is this glycine 624 variant that has been described in other populations as having a hypomorphic effect where you get an intermediate phenotype, and fortunately we do see that as well in our data. And of course, females are going to have less of an effect, so you see a similar pattern there, just a little bit less severe disease. So it's kind of flipping it around, like, if you're seeing patients in clinic, who would you test for Alport syndrome? So this is kind of looking at that way. We categorize the variants as likely pathogenic, and then looked at different phenotype situations you might encounter. So if somebody has, let's say, you're pretty sure they have Alport syndrome, and then you get their genetics. Luckily, that works very well. 75% of them have Alport syndrome that was detectable on the genetic testing. If we took somebody who had dipstick hematuria and family history of CKD, you can see that the third row there was about 5 to 10% depending on the age range of the patient. If they had dipstick hematuria and albuminuria, that's especially for younger patients, that's very good reason to be doing genetic testing. You'll have a decent diagnostic yield, and we don't really know what the appropriate diagnostic yield is. It probably is going to depend, right? So these are some more data that we're trying to piece together to provide some more insights on genetic testing as we get more and more data. And then this is some interesting food for thought just to piece together. But if you have somebody who's undergoing a living kidney donor transplant evaluation, what's the role of genetic testing? If essentially, if they have a family history of familial kidney disease, they probably should get genetic testing. I think there is some controversy there, especially as we're thinking about things like APOL1 and things that may not be as penetrant. But in general, we want to try to understand this question. I was working with Andrew Mallett in Australia and John Sayer in the UK, and we were looking at various genes where they're described as autosomal recessive genes. So let's say you have a patient who has an autosomal recessive kidney disease, and then they have a family member who seems normal. Is there any role of genetic testing to see if they could be a carrier of that gene? So one of these genes that's autosomal recessive is SLC34A3, and this one's interesting because the homozygous version will cause hereditary hypophosphatemic rickets with hypercalciuria. So, you're going to waste phosphate in the urine. That's going to stimulate calcitriol production. You'll have calcium hyperabsorption, and then you'll have lots of urine calcium and risk of nephrolithiasis and nephrocalcinosis, and your urine phosphates will be very high as well. So this one had kind of come up in our clinic when we were doing genetic testing, so we wanted to look at it in more detail. And this particular variant is common in non-Finnish Europeans, or fairly common for a rare variant. And so it was associated with increased risk of nephrolithiasis in our cohort. I think we had like 200 some patients that have this variant, and it's also associated with having a phosphate level less than 2.5, and also eGFR less than 60, which is kind of interesting. One of the other things that we noticed is it seemed like the females were at higher risk of nephrolithiasis than the males, which is sort of the opposite of the pattern you see in nephrolithiasis. And there's something that I'm working on with a medical student trying to extract calcium and vitamin D supplement data, which is very challenging. But there seem like there's more calcium supplementation, vitamin D use in this population for the females. So we're wondering, could that be a potentially modifiable risk factor? Because you can imagine, if you have this, you probably shouldn't be taking calcium supplementation unless there's some very clear reason to be doing so. Vitamin D, I think, is probably a little bit more complicated, but kind of would argue if you can find something that justifies the genetic testing where it would be useful to actually personalize your therapy, then it could be helpful. We have some patients that have the autosomal recessive form, and their phosphate levels are low, so you actually give them phosphate supplementation, and that will reduce their calcitriol levels and reduce their 24-hour urine calcium. Seems like similar things could happen for heterozygous disease, but I don't think there's enough data to say that for sure. So we have a few patients in clinic. We're trying to figure out what to do with them. As I mentioned, we're looking at various autosomal recessive genes. This is the list. There's a lot of genes, and you can see there's a lot of different types of phenotypes on these lists. When you're wondering what's on these genetic kidney disease panels, a lot of these various genes are on there. And I think I put this slide up here just to show that there's all sorts of different phenotypes associated with them. Some of them have been associated with nephrocalcinosis or young onset ESRD, renal tubulopathies, cystic disease, and some of them overlap multiple phenotypes. So that gets tricky when you're trying to figure out what you do, or if you get an unexpected genetic result when you're testing a patient. So always look it up, and if you're not really sure, you can talk with experts and to see that working on specific genes on these different gene panel groups to understand what you're seeing and whether it's actually meaningful or not. So anyways, we had looked at these various genes and to do gene burden tests where we see, okay, if you have pathogenic mutations in these various genes, if you're heterozygous for them, does that put you at any higher risk? And of course, col4A3 and col4A4, now we know there's autosomal dominant form, so that you can ignore that one. But some of the other ones, the SLC34A3 one came up, as we showed before, SLC34A1, IFT140 we described before. That's the third most common cause of ADPKD. An interesting one is Claudin-10, and this is associated with lower EGFR and higher risk of gout and lower and increased risk of CKD. This is also shown in the UK Biobank as well. So I actually had a resident look through all the data of these patients, and it didn't really seem like they had any sort of obvious electrolyte, calcium or magnesium disturbance that was detectable, but they definitely had higher risk of CKD in our data, and so that's something that we're looking at more. So I think that genetic testing can be very useful in differentiating different ADPKD cases. You get a higher yield than typical presentations, but you probably already know if it's going to be PKD1 or PKD2 in those situations mostly. But you do have a lot more genetic heterogeneity in atypical presentations, and I think that could be useful to provide reassurance sometimes if you're not really sure what's going on, and okay, it's one of these lesser genes, or then that's good. The caveat to that is that not all PKD1 genotyping is going to be perfect, so there are still going to be some undetected cases. So if there's a question, just try to talk with the geneticist as well. They get more information about what other testing may be needed. Autosomal dominant Alport syndrome can range from asymptomatic to progressive end-stage kidney disease, and it looks like most cases right now are being undiagnosed. So really have a high suspicion for microscopic hematuria and albuminuria. There is no targeted treatment for it, but I think the good thing is if you do know about the risk, then you could screen more actively for albuminuria and be able to get them on appropriate treatment with ACE inhibitors as needed. And we don't have data on SGLT2 inhibitors, but it seems like there's more and more data on them in other types of diseases. And then the prevalence of genetically defined kidney disease will become much higher when we're doing more genetic testing. So the positive is earlier diagnosis, but then you're also going to have a lot more asymptomatic, pre-symptomatic cases where the patients might come to you with some genetic test result, and you're scratching your head like, I don't know why this 40-year-old guy has the COL4A5 variant, but they're totally fine, which actually happened recently. There was somebody who was getting some kind of for their ethnic group, it's the custom for them to do some kind of genetic testing panel, and they were found to have this variant, and people were asking me, what does that mean? I don't know what it means, but it does happen where you could have one of these things, and we're going to have to take that into account when we're learning how to provide adequate genetic counseling in these cases and really understand the risks and benefits. Potential future research directions, evaluate other risk factors, genetic or lifestyle for affecting rate of decline in ADPKD. We'd like to evaluate, why do some patients with autosomal dominant Alport syndrome progress and others don't? And are ACEs and ARBs protective in that scenario? There's more data in X-linked Alport syndrome, but you'd expect that it should be protective for autosomal dominant as well. And then, want more data and more diverse cohorts using all of us, Mass General Biobank. And then also we're working on some computerized decision support in the sort of the pre-implementation stage right now, but eventually would like to try to be able to roll the stuff out to help clinicians identify patients in need of genetic testing, and then also to what you should do for those particular cases. And then I'm happy to say that it sounds like we have some preliminary approval to start doing a return of results program for the X-linked Alport syndrome, because a lot of those patients, as I mentioned, some of them are diagnosed, some of them probably know they have Alport syndrome, but a lot of them have not actually had genetic testing before. So I think it does make a big difference when you actually have the genetic test results and you can share it with your family and have that definitively. All right. Well, thank you guys very much for your for listening, and please feel free to ask any questions.
Thanks, Alex, for that wonderful overview. I think the more and more we see this data, the more and more we feel that everyone should have whole exome sequencing, especially anyone who's walking in a kidney disease clinic. That's probably an extreme opinion still. But from the view of what you do in the MyCode study, do you have like a genetic counselor, or is it just for research purposes? How are you using that data? What are the logistics of doing this on such a large scale?
Yeah, right. So the exome sequencing right now is not in a CLIA certified environment. So, if you're going to return the results, they have to rerun the analysis in a CLIA certified lab, and then follow a whole pipeline with a genetic counselor, and they have this whole protocol set up to do this. So right now we're not doing it for ADPKD or Alport Syndrome. We're doing our own clinical genetic testing in clinic, and there are a few patients that happen to be my patients, and I'm studying them at the same time. So, but I would order clinical genetic testing in those situations. But yeah, the role of the genetic counselor, I think, is going to be very important. We don't really have resources at the time to support like a full-time genetic counselor in our clinic, but we have been able to partner with one that we can funnel most of our genetics referrals to, and then they can expedite things. It's a lot easier to order genetic testing now than say 2 years ago. And so a lot of the nephrologists will order their own genetic testing, as we've sort of figured out how to do it and got that pipeline set up. Some of the people are not comfortable ordering it and would prefer just to put a referral into the counselor to, or the geneticist will typically see the more complicated cases, but they'll always be free to interact and have questions. But yeah, ultimately, I would love to be able to start up like some kind of a genomics pathology board, style thing where you kind of go over everything, so that's kind of the big picture, hopefully in the future.
Yeah, that's true. Pierre Brown runs our nascent genetics program.
Yeah, it's very nascent. Thank you, Alex. That's fantastic rounds. I wanted to pick maybe your brain a bit more clinically. I have a keen interest in ADPKD amongst other things, but I do order a fair amount of genetic testing. It's kind of nice when you get the typical expected results, but I think you touched on a point where you have these patients, they have multiple kidney cysts, they may or may not have a family history, but they may not be typical, kidneys are not that large, GFR is better than you thought for their age. Which ones do you send for expanded panel? Because you said, you may or may not test them. Like, what's your kind of approach to who do you send for a more expanded panel? And then maybe a second question. Obviously, you probably do your own panels, but you talked about some of the novel genes you've identified. Do you know if these have been picked up by commercial labs that those of us who don't have a genetic lab next door can send to?
Yeah, those great questions. So if I'm seeing a patient in a PKD clinic, so I think if they have very typical disease and, I'm planning on putting them on tolvaptan because, they have very severe disease and there's been a whole lot of questions beyond that, then I don't necessarily do the genetic testing. I often will ask the patient if they would like genetic testing, just if nobody in their family has before, just to actually have the variants. And, I kind of tell them that it may not have a lot of personal benefit for you, but I think it's helpful just because, these diseases are rare and we need to understand them. And there might be some role in the future if, one of your family members wants to donate a kidney. When you have kind of those more intermediate cases where you have mild cystic kidney disease and no family history, or maybe they have like a couple of gigantic renal cysts and no family history, something weird, or they have some spotty family history, whereas some people think they have cystic kidney disease, but nobody's on dialysis. Those are situations where I like getting the genetic testing. We usually have been using this Natera commercial panel just because it does have most of those genes. I think there is one of them that it did not have, but should have in the near future, and I don't want to misspeak which one that was. And then I think sometimes when we refer them to clinical genetic counselor, they might use a different genetic testing platform. And so I think the important thing for the clinicians would just be to be aware of what's actually on those testing platforms. And also, if you're asking a geneticist or genetic counselor to weigh in, you have to realize that they're not experts on everything. So you're still the kidney expert. So you really should guide them in terms of what you're suspecting. So if you really want them to look at all these genes that are related to cystic disease, I would just write that on the order that you want those things tested. They can figure out what the easiest way to do that is. We don't actually have our own genetic lab, so everything we're doing is through commercial labs. So how are you guys doing it over there?
Yeah, sorry, I was just texting you in the chat. Interestingly, so yeah, big fan of Natera. Unfortunately, with our universal system and our single payer has only a bunch of approved or pre-approved labs that you can make a request for funding and then coverage. And Natera is not on them because they're too new, and that's a bit disappointing because they probably offer the best kind of commercial panel. So we use a lot of Prevention and Blueprint, which are great, but as you know, like may not be as comprehensive. But yeah, very similar approach to you, kind of case by case, depends on if I think it'll inform the patients and their family members. So anyways, thanks. That's very informative.
Oh, great.
The stuff about if there are no questions, I can ask one last question. In your PKD with the genotype first approach, there was the huge discrepancy, especially if we include the missense variants.
Mm-hmm.
So what were these patients? Were these patients who had milder PKD? Like clinically, what was going on with those patients? Maybe
Right.
I missed this. But...
Yeah, so I don't remember all the patients because there was quite a few. So, but and we have even narrowed it down from a larger list of possibly pathogenic missense variants. So that was like as well curious as you could get. And then yeah, so the patients that it was like 1/3 of them had ADPKD. So like the 2/3 that didn't, they might have been 40, 50 years old and they had a CT scan and their kidneys looked totally normal. I mean, it would if you saw it, you'd be like, there's no way this patient has ADPKD. It just doesn't make any sense. So that's where, yeah, and it's hard to say, to comment on each individual variant because we might only have like 1 or 2 patients with a specific variant, and maybe it's described in one case report before, right? So I think, yeah, basically we're going to have to, as a nephrology community, kind of collate all this data together in a meaningful manner, and then we can help resolve some of these issues with some of these, especially the missense variants. It's hard to know which ones are truly pathogenic or not.
Yeah, but even with the hematuria, with the Alport, what we're showing is often we get all these young people with microscopic hematuria. They have got nothing else. We get a urology workup done. It's all clear. And, we kind of, I used to kind of tell them, hey, maybe you've got thin basement membrane disease or something. Let's just ignore it. You're fine. But maybe we should be doing these in them and give them a more, granular advice about, hey, maybe these guys we should be following up and these guys maybe not.
Yeah, I think if everything was paid for, that would be great for sure. I mean, I guess if you can't get it paid for in some of those instances, then you exactly what you said. You might be this. Hopefully the data I give you provides some context on what the potential risk is. It's not like it's not super high, but it's certainly increased compared to the general population. And then, it's not definitive that they're going to develop kidney failure or anything by any means, but good to follow them closely.
For sure. Yeah, so I think we are at the end of the hour. So thanks again, Dr. Chang, for that really thought-provoking talk and excellent discussion. We are entering a brave new world here.
Absolutely. Yeah, keep in touch on any genetic testing questions. Happy to help out, because these cases are rare, and I'll be honest, I reach out to Tony Blyer all the time for a lot of ADPKD questions anytime there's some kind of UMOD abnormality or something. So if you ever have a patient where there's something that pops up, you're not sure, feel free to reach out, and happy to try to help out.
Thank you.
Okay, take care.